Good afternoon, our dear students. Today we have a next lecture from endocrinology. The topic of our today's lecture it is diseases of adrenal glands. And here we're going to discuss adrenal insufficiency, adrenal hyperfunction, and hormonally active tumor, such an important and underestimated groups of disease that really be interesting for you. As usual, my name is Maria Brins. I'm head of Propaedeutic of Internal Medicine and Physical Rehabilitation Department. Let's start our lecture. And before we start working with the topic, I have several USMLE tests just for your individual work with yourself at home, not for controlling, it's just for you, for your self-controlling. Okay, first test. A 34-year-old woman comes to the emergency department complaining of severe headache and anxiety, diaphoresis and palpitations for the last 30 minutes. She has had several similar episodes over the past few weeks. She has no significant past medical history and has a 10-pack-year smoking history. She takes no illicit drugs. Her blood pressure on arrival is 181 by 80 millimeters hydrorgium and her pulse is 134. The attending physician gives her 10 milligrams of metoprolol. How is the patient blood pressure most likely to respond? And options. First, hypertension due to beta-adrenergic receptor blockade. Second, hypotension due to alpha-adrenergic receptor blockade. Third, hypertension due to alpha-adrenergic receptor blockade. Fourth, hypertension due to alpha-adrenergic receptor stimulation. And fifth, hypertension due to alpha and beta adrenergic receptor blockade. Who knows this effect? It is ideally, something maybe about adrenal gland disorders and about pharmacology. Who don't know the answer, please be attentive during lecture. You should find it in our material. Plan of our today's lecture. It is definition, epidemiology, risk factors, etiology. I'm going to discuss as usual mechanisms, classification, clinical presentation, diagnosis, treatment, prognosis, and prophylaxis of adrenal glands disorders. And here you see pictures with position, anatomical position of adrenal gland that like line upper on kidneys. Definition. Diseases of adrenal glands, they are a condition that interfere with the normal functioning of adrenal glands and may cause hyperfunction or overactive adrenal glands or hypofunction with underactive adrenal glands and may be congenital or acquired. There are two parts of adrenal glands. You remember it from anatomy. The cortex derived from mesenchymal cells and the medulla inside derived from neuroectodermal cells. First one produces mineralocorticoids, glucocorticoids and androgens. And second one produces epinephrine or adrenaline and norepinephrine or noradrenaline. Epidemiology of adrenal gland disorders. I give you like an example the Japan epidemiology because it is one of the most estimated, one of the best described epidemiology and in a better way calculated epidemiology. Okay, in Japan, in year 1997, for example, the total numbers of patients were estimated as 1,450 for primary aldosteronism, 1,250 for Cushing's syndrome, 90 for adrenal preclinical Cushing's syndrome, 660 for Addison's disease, and 1,030 for pheochromocytoma. You see that it is not a very often disorders, like for example diabetes mellitus, previous lecture on one lecture before it, like thyroid gland disorders, when every 10th, every 15 adult person in the world can have this disease. But these disorders are much more rare, but we see it in a real clinic, and you will see it during your practice. These disorders are quite difficult for management and quite serious for patient. That's why we should know what it is. Risk factors. There does not appear to be a particular group who is most at risk for adrenal gland disorders. While there are certain risk factors for adrenal gland disorders, most of them occur without apparent cause. Where risk factors are absent, the risk of development adrenal diseases may be increased by genetic predisposition, by a problem in another gland, such as the pituitary gland, or when a disease or infection affects one or both of the adrenal glands, and certain lifestyle behaviors and maybe environmental factors such as smoking and exposure of cancerogens. Adrenal gland disorders appear to affect men, women, and children equally and may develop at any age. Etiology. First of all, we told that they can be congenital, that some congenital anomalies in a way of different genetic mutations can lead to adrenal gland diseases. It can be immunopathology. The adrenal gland problems can be a result of different infections. The most often of them are tuberculosis, acquired immune deficiency syndrome, or AIDS. A problem in another gland, such as pituitary, which regulate the adrenal gland, can lead to adrenal gland problem. You remember from thyroid, yes? When it is central problem, we need name it secondary. And the same with adrenal gland, it's regulated through pituitary too. And if something from pituitary overproduction or hyperproduction of something leads to dysregulation of adrenal gland and adrenal problems, we name it secondary too, according to diagnosis. Tumors including pheochromocytomas, and pheochromocytoma can be in adrenal gland or not in adrenal glands, we will discuss. It can be bilateral adrenal hemorrhage or infarction lead to damaging of adrenal tissue and, for example, insufficiency. It can be result of medical manipulation like bilateral adrenal ectomy, and it can be a result of using of certain medicines. Mechanisms. Major disorders of the adrenal cortex are characterized by excessive or deficient secretion of each type of adrenocortical hormone, accordingly to interference of etiologic and pathogenetic factors that include distress, injury, vascular reactions, thrombosis, necrosis, acute and chronic inflammation, dystrophy, hypertrophy, neoplastic processes, etc. The most common disorders of adrenal medulla is pheochromocytoma that originates from chromaffin cells and excretes catecholamines. But pheochromocytoma may be referred as a secreting paragangliomas when found in extraadrenal chromaffin cells. Neoplasms such as neuroblastomas and ganglioneuromas may be also the neuronal lineage. Okay, in international classification on diseases, we find them in chapter 4, endocrine, nutritional and metabolic disorders, and we code adrenal gland diseases in codes from E00 to E19. We can find it here. You see on the slide there separate diagnoses. Okay, and clinically, according to what happened, you understand that adrenal problems, adrenal disorders, it is a big range of different diseases. What the main of them, according to etiology and according to a problem in function of adrenal glands. It can be adrenal insufficiency, and in opposite to it, adrenal hyperfunction. It can be isolated primary hyperaldosteronism. It can be glucocorticoid remediable hyperaldosteronism. It can be pheochromocytoma. You remember it is tumor from the medullary cells. It can be adrenal hyperandrogenism. You remember that cortex produce androgens. It can be non-classic congenital adrenal hyperplasia. It can be androgen secreting adrenal tumors. It can be adrenal incidentaloma. And it can be consideration of pharmacological use of corticosteroids. Today's lecture I'm going to stop shortly on each type of adrenal problems. Adrenal insufficiency. The most common cause of primary adrenal insufficiency is autoimmune destruction of adrenal glands. The same with the thyroid problem, where the most often cause of them, it is autoimmune attack. The same in adrenal gland. The most often case, it is autoimmune attack against pancreas cortical cells that results in adrenal insufficiency. We name this disorder like Addison's disease. It is from 70 to 90% of all causes of adrenal insufficiency. Some other cause, it is this 10-30%, include bilateral adrenal hemorrhage, using some drugs like mitotan, etomitate, ketoconazole. It can be a result of some infection diseases like tuberculosis, HIV, disseminated histoplasmosis, paracoccidomycosis. All these causes, all these factors can affect glucocorticosteroid and mineralocorticoid secretion and may be fatal if untreated. It really serious illness. Addison's disease may coexist with other autoimmune conditions such as type 1 diabetes mellitus, hypothyroidism, and hyperparathyroidism. And if you stop on it and think a little, all these diseases are autoimmune. That's why you understand that we have often combination of these disorders with polyglandular autoimmune syndrome, with autoantibodies that affect different glands in organism and can lead to diabetes, to hypothyroidism, to hyperfunction of adrenal glands or hypoparathyroidism. And it can be secondary and tertiary. I told you that the problem, the same logic with thyroid gland, the same with adrenal problem, can go from the regulation from hypophyse or pituitary gland and hypothalamus. Secondary and tertiary adrenal insufficiency occur commonly after the discontinuation of glucocorticosteroids. Less frequently, adrenocorticotropic hormone deficiency may be caused by pituitary macroadenomas, pituitary surgery or radiation, and paracellular diseases. Megestrol acetate, an appetite stimulator used in some patients with advanced cancer or cachexia related to AIDS, and may be associated with secondary adrenal insufficiency, the same mechanism. Tertiary adrenal insufficiency from inadequate secretion of corticotropin-releasing hormone. It goes even upper from hypothalamus. Secondary and tertiary adrenal insufficiency only affect cortisol secretion because ACTH has only a minor role in regulation of aldosterone secretion. ACTH, you remember, adrenocorticotropic hormone from pituitary gland. Manifestations. All patients with primary adrenal insufficiency complain of fatigue, anorexia, and weight loss. Skin hyperpigmentation, initially on the extensor surfaces, palmar creases, and buccal mucosa, results from increased level of ACTH and other pro-melanocortin-related peptides, including melanocyte-stimulating hormone. Secondary adrenal insufficiency manifests more insidiously with lack of skin hyperpigmentation, salt craving, metabolic acidosis, and hyperkalemia, because mineralocorticoid secretion is intact. Fatigue, hyponatremia, and hypoglycemia are some of the clinical manifestations in secondary adrenal insufficiency. Okay, symptoms, signs, and laboratory abnormalities. Let's systematize all clinic of adrenal insufficiency. Symptoms. What is subjectively in patient? What feel patients? It is weakness, fatigue, anorexia, nausea, vomiting. It's often constipation, but possible diarrhea. It can be abdominal pain, salt craving, postural dizziness, muscle and joint pain. It is the most often features. Signs. What can we find during examination? It is weight loss. It is hyperpigmentation of skin. It is vitiligo. And usually in such patients, systolic blood pressure less than 110 millimeters hydrorgia. Laboratory abnormalities. They are very typical for adrenal insufficiency and usually include hyponatremia, hyperkalemia, hypercalcemia, azotemia, anemia, and eosinophilia. And one more time, schematically for objective examination, one more time, the most specific objective signs. It is hyperpigmentation of skin. It looks like a patient spent a lot of time on the sun, and it is a very dark bronze skin, but it's not a very healthy color of skin, but it is very dark, and sometimes you can make a mistake and thought that it's just a sun result. It can be systemic features, one more time, like low blood pressure, weakness, weight loss. It's typical GI symptoms like nausea, diarrhea, vomiting, constipation, abdominal pain, and on skin it is possible vitiligo. Yes, on dark skin it can be places of depigmentation, local depigmentation. And you see here at the left on table signs of adrenal crisis. It is the most severe form of adrenal insufficiency that include fever, syncope, convulsions, hypoglycemia, hyponatremia, severe vomiting, and diarrhea. It is an emergency, quite danger state that can lead even for death. Evaluation. Evaluating of patient with suspected adrenal insufficiency. It is a three-step process. Step 1, it is establish a diagnosis. Just to answer, is it present insufficiency or not present insufficiency? Second step, it is differentiating between primary and secondary adrenal insufficiencies. And step 3, it is looking for the cause of adrenal insufficiency, not just like syndrome primary or secondary, to find a cause if it's possible. First step, for it we use an early morning plasma cortisol level. If it is lower than 3 mg per deciliter, it confirms adrenal insufficiency. Whereas a value higher than 15 makes the diagnosis highly unlikely. Cortisol levels in the range of 3 to 15 may be seen in patients with primary, secondary, or tertiary adrenal insufficiency, but you need more investigations to confirm it. These patients should be evaluated by cositropin or cortrosine stimulation test at any time during the day. Algorithm of diagnosing of confirming presence of adrenal insufficiency you see in table on this slide. Please work with it at home. Okay, differentiation. Step 2 between primary and secondary adrenal insufficiency. It's done through the measurement of the basal plasma ACTH level. ACTH level. ACTH, it is a hormone that produced by pituitary gland, you remember. An elevated ACTH level consistent for primary adrenal insufficiency. A low or normal range ACTH level with a low cortisol level confirms the diagnosis of secondary or tertiary adrenal insufficiency. And step 3, how to determine cause, and is it possible always find a cause of adrenal insufficiency? When the biochemical workup is consistent with primary adrenal insufficiency, it recommended computer tomography scanning of adrenal glands. Enlarged adrenal glands or calcification suggest an infectious, hemorrhagic, or metastatic cause of adrenal insufficiency. In rare circumstances, CT-guided percutaneous fine needle aspiration of enlarged adrenal glands may help establish a diagnosis. Patients with tuberculosis insufficiency usually have evidence of active systemic disease, active systemic tuberculosis. MRI of pituitary gland is indicated if glucocorticosteroid therapy as the cause of secondary adrenal insufficiency has been ruled out. A little bit USMLE test for your interest about this part of lecture. Question 2. A 53-year-old nurse presents to the emergency department after experiencing a syncopal episode at work. She reports a 6-month history of worsening fatigue, 20-pound weight loss, and dizziness when standing up from the sitting position. Her PMH is significant for hypothyroidism, for which she takes levothyroxine. Her blood pressure while supine is 150 by 60, which falls to 75 by 50 when standing. On exam, she appears fatigued, and you note a hyperpigmentation of gums as shown on figure. No, it's no figure here, but it is hyperpigmentation of gums. Labs are notable for sodium 128 millimoles per liter and potassium of 5.6 milliequivalent per liter. Which of the following is most likely pathology underlying this presentation? First option, it is autoimmune adrenalitis. Second, infection adrenalitis. Third, hemorrhagic infarction of the adrenal glands. Fourth, metastatic disease involving the adrenal glands. Fifth, medication-induced suppression of adrenal glands. Okay, treatment of adrenal insufficiency. Patients with Addison's disease require lifelong replacement with glucocorticosteroids and mineralocorticoids, as usually in endocrinology. If we have deficiency, we replace this hormone. The dose is adjusted based on clinical status, including the presence or absence of orthostatic hypotension, hypertension, and electrolyte imbalance. Patients with secondary or tertiary adrenal insufficiency do not need mineralocorticoid replacement. Most patients can be educated to self-administer hydrocortisone and reduce risk for an emergency room visit. All patients should wear some form of identification indicating their adrenal insufficiency status. Now I will show you. It looks like this. Usually such patients wear some necklaces or bracelets They are absolutely essential and containing information on their diagnosis and treatment regime, because I told you a little bit we have such situation like severe adrenal insufficiency. Patient can get very quickly unconscious, and even some people in the street, some even not medical workers, have know what to do with this person, because person can die. This situation, one more time, we name adrenal crisis or acute adrenal insufficiency. It is life-threatening emergency which usually manifests with nausea, vomiting, abdominal pain, abdominal tenderness, fever, acute abdomen, and shock. Patients may be previously undiagnosed or have chronic primary adrenal insufficiency with or no or inadequate glucocorticosteroid replacement. Treatment of adrenal crisis should not be delayed. Diagnostic workup in patient with no history of adrenal insufficiency should include plasma sample for cortisol and ACTH level determination. Immediately followed by IV bolus of hydrocortisone 100 mg and adequate fluid replacement, normal saline replacement. Even not waiting for result of analysis. We take blood for analysis and inject 100 mg of hydrocortisone if we suspect adrenal crisis, because a situation is really emergent. Hydrocortisone should be continued 50 mg every 8 hours while awaiting laboratory results. Next test for you is test 3. 46-year-old female with history of type 1 diabetes mellitus presents with complaints of chronic fatigue, muscle weakness, and headaches. These symptoms have been present for the past year. Her vital signs today are as follows: temperature 36.9, heart rate 82, blood pressure 88 by 52, respiratory rate 15, saturation 98 on room air. Physical exam does not demonstrate any specific abnormalities. After MRI, the patient reports that her blood pressure has always run low. Initial workup reveals an 8 a.m. cortisol level of 3.6. Which of the following is the best next step in management of this patient? First option, it is low-dose dexamethasone suppression test. Second, high-dose dexamethasone suppression test. Third, urgent 5 mg hydrocortisone injection. Fourth, cosintropin stimulation test. And fifth, pituitary MRI. Okay, adrenal insufficiency in critically ill patient. It is a little bit separate form of adrenal insufficiency. The overall incidence of insufficiency in critically ill patients is less than 10%, but the incidence as high as 50% in patients with septic shock has been reported. Intensive care unit patients with hemodynamic instability, despite fluid resuscitation, especially in presence of shock, should be tested for adrenal insufficiency. Hydrocortisone 50 mg IV every 6 to 8 hours is an adequate replacement dose for critically ill patients with suspected adrenal insufficiency. Treatment with this dose should be continuous 2 or 3 days. After hemodynamic improvement, the gradual taper of hydrocortisone, depending on the patient's condition, should be instituted. And next syndrome for today, next disorder, it is adrenal hyperfunction. Disorders related to adrenal hyperfunction are relatively rare, but they have significant mortality and morbidity if untreated. When the adrenal glands produce too many hormones, the symptoms vary depending on the disorder. Disorders related to adrenal hyperfunction include: the most often it is Cushing syndrome, If it is isolated hyperproduction of aldosterone, we name it primary hyperaldosteronism. If it connected with medullary cells, it is pheochromocytoma or paraganglioma, and we can include here hormonally active tumors. Cushing syndrome. Let's give definition and classify it. Cushing syndrome is composed of symptoms and signs associated with prolonged exposure to inappropriately high levels of plasma glucocorticosteroids. Exogenous glucocorticosteroid intake is the most common cause of Cushing syndrome. The endogenous causes are divided into ACTH-dependent and ACTH-independent Cushing syndrome. And on this slide, I show you the most often symptoms and clinical picture of Cushing syndrome, because a general view and general inspection of patient with Cushing syndrome is very specific. If you will see one more time Cushing patient, you will not mix it with other during all your life. Schematically on this picture, you see how nearly look the female with Cushing, and main symptoms and signs for this syndrome. It is upper body obesity with thin arm and legs. It is buffalo hump. By arrow it showed you on picture. It is round face, high blood sugar, high blood pressure, vertigo, blurry vision, acne, female balding, water retention, menstrual irregularity, thin skin and bruising, purple stria, poor wound healing, hirsutism, severe depression, cognitive deficits, emotional instability, sleep disorders, and fatigue. And I told you that endogenous can be ACTH dependent and ACTH independent. It's what we usually name primary or secondary. ACTH dependent. It is Cushing syndrome. It is 67 cases of Cushing, of adrenal hyperfunction at all. The most often case, and it is primary. And ACTH dependent can be ectopic ACTH secretion and ectopic CRH degradation that in a structure of adrenal hyperfunction takes 12% and less than 1% relatively. ACTH independent cases include what we usually earlier name secondary. It is adrenal adenoma 10%, adrenal carcinoma 8%, and micro and macronodular adrenal hyperplasias nearly 1%. You see the structure a little bit different. That's why for adrenal hyperfunction we have a quite different classification. Clinical features. I show you 2 slides ago schematically on the picture. Let's divide one more time the most typical features. More specific signs and symptoms. It is plethora. It is supraclavicular and dorsal fat paths. It is central obesity, proximal muscle weakness, cutaneous wasting, purple stria, spontaneous ecchymosis, osteopenia, hypertension, early or delayed puberty in children, growth retardation in children. Less specific symptoms and signs, but possible for Cushing. That's why it gives you additional information, additional confirmation for your diagnosis. It can be papular acne, venous hypertrichosis of face, decreased libido and impotence, oligomenorrhea or amenorrhea in female patients, infertility, cutaneous systemic fungal infections, poor wound healing, nephrolithiasis and polyuria, headaches, neuropsychiatric disorders, and spinal epidural lipomatosis. And one more time symptoms schematically for objective examination. What we paying attention for? It can be central nervous system irritability and emotional disturbances. It is red and round face with fat parts on the body. It is hypertension, cardiac hypertrophy we can find, and we usually find in Cushing patients during objective examination. It can be hyperplasia and tumors of adrenal glands during studies. In most patients, we see purple stria. Most patients are obese due to central obesity. It can be osteoporosis, muscle wasting, and skin ulcers. Establishing. What can we see here? You see on this slide, it is algorithm of establishing a diagnosis Cushing syndrome. What test we use? First, it is 24-hour urinary free cortisol determination, or UFC. Next test, 1 mg dexamethasone suppression test, or DST. It is midnight salivatory cortisol test, low-dose dexamethasone suppression test, or LDDST, and International Prognostic Scoring System, IPSS, that we usually for establishing a diagnosis. And by the algorithm, you see that we do, if in case of clinical suspicion, we do 24 hours UFC. According to its result, and additionally we can do 1 mg dexamethasone test. If both of them normal, it is no further workup. If 3 times upper normal, additionally we establish Cushing syndrome and do ACTH, and according to its level we decide, is it adrenal, is it pituitary, is it hypothalamic, etc. And is it equivocal? Additionally, we can do LDDST and CRH test. Differential diagnosis. Once Cushing syndrome is biochemically confirmed with blood tests, a plasma ACTH level should be measured, preferably in the morning. A suppressed or low ACTH level less than 10 picograms per milliliter is consistent with ACTH-independent Cushing syndrome and should be followed by adrenal CT scanning. ACTH values from 10 to 20 picograms in milliliter may be seen in patients with both adrenal and pituitary causes of Cushing syndrome. These patients should undergo a CRH stimulation test. A flat response of ACTH and CRH during the test suggests an adrenal caused by a more than 15% increase in the ACTH level during the test is consistent with Cushing's disease. ACTH level higher than 20 picograms per milliliter suggests ACTH-dependent Cushing syndrome. About 90% of patients with ACTH-dependent Cushing have a pituitary cause, or the rest are ectopic in origin. ACTH level tend to be higher in ectopic Cushing syndrome compared with Cushing's disease, but there is significant overlap. A more than 15% increase in the ACTH level after the CRH test and a more than 80% reduction in the morning cortisol level from 8 to 9 a.m. after taking 8 mg dexamethasone and 11 p.m. during the high-dose DST is consistent with pituitary source, and in the presence of pituitary adenoma almost established a definitive diagnosis of Cushing syndrome. If it was quite quickly. Who did not understand, please stop on 2 previous slides to understand how to differentiate different forms of Cushing syndrome. If the CRH stimulation test and dexamethasone test results are not concordant and MRI does not show a pituitary adenoma, then inferior petrosal sinus sampling to distinguish ectopic from Cushing's disease is indicated. Localizing tumors that produce ectopic ACTH is accomplished by chest and abdominal CT studies, followed by neck CT if no source is found. An octiotyte scan may be some value in patients with ectopic Cushing syndrome and negative imaging studies. Next test for you. A 35-year-old Caucasian female presents to the hospital alarmed by her recent truncal weight gain, facial hair growth, and thinning skin. During the physical exam, the physician finds that patient is hypertensive. Serum analysis reveals hyperglycemia. The physician suspects a pituitary adenoma, which dexamethasone test result would help confirm the physician's suspicion. How to confirm? First option, low dose increased ACTH, high dose increased ACTH. Low dose increased, high dose decreased ACTH. Low dose decreased, high dose no change ACTH. Low dose no change, high dose no change ACTH. And fifth one, low dose no change, high dose decreased ACTH. Treatment of Cushing syndrome. It can be surgical. It is transsphenoidal removal of ACTH secreting pituitary tumor is a treatment of choice. Cushing syndrome caused by adrenal adenoma is usually cured by laparoscopic unilateral adrenalectomy. Adrenal carcinoma is an aggressive tumor with poor prognosis, surgical resection at an early stage along with a lifelong mitatan therapy soon after surgery offers the once a chance for cure of long-term remission. Surgical removal of an ectopic ACTH-producing tumor results in cure. Medical therapy with ketoconazole, metirapone, aminoglutamate, or mitatan may be considered for patients with limited life expectancy or for alleviation of hypercortisolinemic symptoms before the surgery. Test 5. A 50-year-old female is evaluated by her physician for recent weight gain. Physical exam is notable for truncal obesity, wasting on her distal musculature and moon faces. In addition, she complains of abnormal strange marks that surround her abdomen. The physician suspects pituitary adenoma. Which of the following high-dose dexamethasone suppression test finding and baseline ACTH findings would support his view? First option, cortisol suppression, normal baseline ACTH. Second, cortisol suppression, high ACTH. Third, no cortisol suppression, high baseline ACTH. Fourth, no cortisol suppression, low ACTH. And fifth, elevation of cortisol above pre-test levels, high baseline ACTH. Next syndrome for today, it is primary hyperaldosteronism, when it is isolated elevation of aldosterone is not connected with glucocorticosteroids. It can be two forms of familial primary hyperaldosteronism. Primary hyperaldosteronism type 1 of glucocorticosteroid remediable hyperaldosteronism is autosomal dominant disease characterized by chimeric gene between 11 beta hydroxylase and aldosterone synthase with varying degrees of hyperaldosteronism which responds to exogenous glucocorticosteroids. And familial hyperaldosteronism type 2 is an autosomal dominant disorder of both the aldosterone-producing adenoma and idiopathic hyperaldosteronism. Clinical presentation of hyperaldosteronism. Clinical picture varies from asymptomatic to symptoms related to hypertension, hypokalemia, or both. Patients may have headaches, polyuria, nocturia, polydipsia, paresthesias, weakness, and muscle cramps. There are no specific physical findings. The degree of hypertension is usually moderate to severe and may be refractory conventional antihypertensive agents. Malignant hypertension and leg edema are rare. The left ventricular hypertrophy is disproportionate to the level of blood pressure and improves after treatment of primary hyperaldosteronism, even if hypertension persists. Signs and symptoms. You see by the scheme that result of aldosterone excess can be pulmonary with increased prevalence of obstructive sleep apnea, bone changes with increased rate of osteoporosis, urinary calcium excretion, and risk of vertebral fractures. Renal results include higher beta-2 microglobulin excretion, increased prevalence in chronic renal failure, increased cyst formation, higher serum creatinine, inflammation, podocytes injury, fibrosis. Vascular and smooth muscle changes. You see it here. I will not read. You can stop video here and read. Metabolic changes, cardiovascular changes, and neuropsychiatric changes. Laboratory tests for primary hyperaldosteronism. Routine laboratory tests may show slightly high serum sodium levels, hyperglycemia, hyperkalemia, metabolic alkalosis, and hypomagnesemia. Although most patients with hyperaldosteronism are not hypokalemic, a low serum potassium level may be noted either spontaneously or after thiazide or loop diuretic use. Hypokalemia may be severe and difficult to correct. Hypokalemia presence reduces the secretion of aldosterone, and those should be corrected before the laboratory evaluation of hyperaldosteronism. Diagnosis. The workup of patients with primary hyperaldosteronism involves the following steps: screening tests for hyperaldosteronism, establishing the autonomy of aldosterone secretion, and determination of the source of hyperaldosteronism. It can be three categories of patient. First, it is hypertensive with spontaneous or thiazide-induced hypokalemia. Next, it is hypertensive resistant to therapy, and hypertensive with adrenal incidentalomas. I will explain you what is that. And you see algorithm for diagnosis with screening test, confirmatory test, and establishing of aldosterone source. What tests we use here? And visualization, for example, computer tomography. And you see here adrenal adenoma on computer tomography. It's shown by a blue arrow. You see that upper than kidney. We see some round structure. It is tumor. Screening test. Although hypokalemia is a hypertensive in a hypertensive patient is suggestive for hyperaldosteronism. Normokalemia does not exclude the diagnosis. Measurement of 24-hour urinary potassium test can be useful in assessing the cause of low potassium level. Urinary potassium excretion more than 30 milliequals per day in a patient with hypokalemia suggests primary hyperaldosteronism. If plasma renin activity is low, the ratio of plasma aldosterone concentration and PRA is the best screening test for pH. Spironolactone and eplerenone should be discontinued for 6 weeks before testing, not to compensate the situation for putting diagnosis. Low or suppressed PRA during therapy with angiotensin converting enzyme inhibitors or angiotensin receptor blockers suggest hyperaldosteronism. And differentiating between aldosterone-producing adenoma and idiopathic hyperaldosteronism by the test. HTN. It is more severe in aldosterone-producing adenoma and less severe in idiopathic form. Upright posture test decrease less than 30% and increase of serum aldosterone level in adenoma and increase by 30% in idiopathic. 18 corticosterone level more than 100 usually in adenoma, less than 100 nanograms in milliliter in idiopathic hyperaldosteronism. CT. In CT scans, if it is adenoma more than 1 centimeter, we can find it within CT scans. In idiopathic forms, why we name? Because we can't find with CT scans any tumor, any adenoma. And bilateral adrenal venous sampling for adenoma, it's typical lateralization. For idiopathic hyperaldosteronism, it will be no lateralization. Test 6 for you. 47-year-old male presents with a primary complaint of generalized muscle weakness. Serum chemistry analysis reveals a pH of 7.6 and potassium level 3.2. Abdominal CT imaging is positive for 1.5 centimeters nodule noted in the cortical region of the right adrenal gland. Which of the following findings are most likely to be seen in this patient? Option 1, it is increased secretion of renin and renal juxtaglomerular cells. Second, increased serum levels of 17-hydroprogesterone and deficiency of 21-hydrolase. Third, hypotension secondary to decreased plasma aldosterone levels. Fourth, hypertension with a low plasma renin activity. And fifth, increased fractional excretion of sodium and associated hyponatremia. Medical history, clinical findings, and screening. Patient with suspected primary aldosteronism. We should do PRA, it's what we told in estimation, plasma renin activity, PAC, plasma aldosterone concentration, aldosterone renin ratio, you know that it is most informative. 24 hours ambulatory blood pressure monitoring, left ventricle size, levels of potassium, sodium, magnesium, finding aldosterone producing adenoma with visualizing methods, and idiopathic hyperaldosteronism. Treatment. The treatment goals are to reduce the morbidity and mortality. Unilateral adrenalectomy results in normalization of hypokalemia and improvement in hypertension in all patients. Medical treatment is reserved for patients with idiopathic hyperaldosteronism and those with adenomas who are poor surgical candidates. Spironolactone or eplerenone, it is a treatment of choice of hyperaldosteronism. Side effects include painful gynecomastia, nausea, headaches, impotence, and irregular menstruation. Eplerenone that blocks the aldosterone receptor selectively has a better side effect profile. The use of mineralocorticoids is usually not necessary. And algorithm of diagnosing and treatment of hyperaldosteronism here. One more time, stop on it, I will not. Okay, and one of the forms, glucocorticosteroid remediable hyperaldosteronism. Familial hyperaldosteronism type 1 or glucocorticosteroid remediable hyperaldosteronism individuals are younger 40 years usually, exhibit hypertension resistant to standard therapy, and have a familial history of primary hyperaldosteronism or cerebrovascular accident at the young age. Most of them have a normal serum potassium level, a very high urinary 18-hydrocortisol level, or genetic testing to detect a chimeric gene established their diagnosis. Affected individuals should have neurovascular screening for cerebral aneurysms. Treatment with glucocorticosteroids, eplerenone, spironolactone, amiloride, and triamterene is effective. Test 7. A 33-year-old male presents to his primary care physician with complaints of headaches and muscle weakness. His physical exam is entirely within normal limits except for blood pressure of 150 by 95. Subsequent routine blood lab work showed in sodium level of 146 and potassium level of 3. What is the best pharmacological therapy for this patient? First, it is hydrochlorothiazide. Second, spironolactone. Third, propranolol. Fourth, lisinopril. Fifth, fludrocortisone. Next disorder for today, we name it pheochromocytoma. Let's give definition. Pheochromocytomas are rare chromatin cells tumors that may occur at any age. Although their true prevalence is unknown, they occur in about 0.3% of hypertensive patients. If untreated, pheochromocytomas can have severe consequences such as myocardial infarction, heart failure, cerebrovascular accident, and death. Most pheochromocytomas are benign, sporadic, unilateral, and located within the adrenal gland. Extraadrenal pheochromocytomas or paragangliomas occur in about 15 of cases in superior and inferior para-aortic areas, including the zuckercandral organ, bladder, thorax, head, neck, and pelvis. Paragangliomas tend to occur in younger patients, less than 20 years. They are multifocal in about 15 to 30% of cases. Bilateral pheochromocytomas are usually seen as part of familial syndromes. Malignant pheochromocytomas have a higher prevalence in ectopic pheochromocytomas and lower prevalence in familial pheochromocytomas. About 10% to 15% of pheochromocytomas are hereditary in nature. Clinical manifestations. Patients with pheochromocytomas may have proximal hypertension or persistent hypertension, or can be normotensive. Wide fluctuations in blood pressure and resistance to antihypertensive medications are typical of those with pheochromocytomas. The triad of headaches, palpitations, and diaphoresis suggests the diagnosis of pheochromocytoma, but absence of these symptoms does not exclude their diagnosis. Attacks are usually precipitated by emotional stress, exercise, anesthesia, abdominal pressure, or ingestion of tyramine-containing foods. Symptoms include pallor, flushing, orthostatic hypertension, weight loss, dyspnea, polyuria, polydipsia, visual blurring, focal neurological symptoms, and change in mental status. The diagnosis can be established by measuring catecholamines and metanephrines in plasma, or through the 24-hour urine collection. Care should be taken to rule out after causes of adrenergic, adrenaline-like excess, like hypoglycemia, stress, exercise, and drugs. Affecting the catecholamines like stimulants, methyl-dopa, dopamine agonists, or ganglion blocker antihypertensives. Various foodstuffs like coffee, tea, bananas, chocolate, cocoa, citrus fruits, and vanilla can also affect the levels of urinary metanephrine and vanillyl mandelic acid. Imaging studies of the head, neck, chest, and abdomen can help localize the tumor. Test 8 for you about pheochromocytomas. 49-year-old male presents with a primary complaint of several recent episodes of severe headache, sudden anxiety, and racing heart. The patient originally attributed these symptoms to stress at work. However, these episodes are becoming more frequent and severe. Laboratory evaluation during such an episode reveals elevated plasma-free metanephrines, which is following additional findings in this patient is most likely. Option 1. Decreased 24-hour urine vanillyl mandelic acid levels. Second, episodic hypertension. Third, anhidrosis. Fourth, diarrhea. Fifth, hypoglycemia. Imaging studies of pheochromocytoma. Here you see on picture CT scans. First scan, it's showing 2 centimeters left adrenal mass. It marked by 1 in the round. Second, it is MRI imaging showing large adrenal mass. You see on the right side, but in patient it is the left. You understand, a big tumor mass. And the last one, it is MRI showing large right adrenal mass too. It's showed by arrow. Treatment of pheochromocytoma. Surgical resection of the tumor is a treatment of first choice. Either surgical options requires prior treatment with the non-specific and irreversible alpha adrenal receptor blocker, phenoxybenzamine, or a short-acting alpha antagonists like prazosin, terazosin, or doxazosine. Once the pheochromocytoma has been resected, thereby removing of major source of circulating catecholamines, a situation arises when there is both very low sympathetic activity and volume depletion. This can result in profound hypotension. Therefore, it is usually advised to salt load pheochromocytoma patient before their surgery. Test 9. A 34-year-old female presents to the emergency room with headache and palpitations. She is sweating profusely and appears tremulous on exam. Vital signs are as follows: heart rate 120, BP 190 by 110, respiratory rate 18, and saturation 99 on room air, temperature 37. Urinary metanephrines and catechols are positive. Which of the following medical regimen is contraindicated as a first-line therapy in these patients? First, it is phenoxybenzamine. Second, nitroprusside. Third, propranolol. Fourth, labetalol. Fifth, lisinopril. And the next disorder for today, it is adrenal hypergonadism. The adrenal glands are an important source of androgens, especially in children and women. The primary adrenal androgens, dehydroepiandrosterone and dehydroepiandrosterone sulfate, are under ACTH control and have little intrinsic androgen activity. However, they are converted to androstenedione and then to testosterone or estrogen in both the adrenal gland and peripheral tissues. The hair and the hair sulfate are responsible for adrenarche or pubic hair development. PAC levels occur the third decade of life and decline progressively to 25% of peak levels around the age of 80 years. If it manifested in childhood, we see in female neonates androgen excess causes female pseudohermaphroditism or ambiguous genitalia. Male infants exhibit penile enlargement. At propuberty, androgen excess manifests in increased rate of growth in height and skeletal maturation with premature epiphyseal fusion and short adult height. Boys exhibit penile enlargement, hair growth in androgen-dependent areas, deepening of the voice, and other secondary sexual characteristics. Girls have hirsutism, acne, and clitoromegaly. At puberty, androgen excess causes premature skeletal maturation and short adult height in boys. At amenorrhea, different degree of virilization and increased skeletal maturation resulting in a short adult height in girls. In men, a decrease in size of testicles, testosterone secretion, and spermatogenesis caused by inhibition of gonadotropin secretion may occur. In women, hirsutism, acne, menstrual irregularities, male pattern baldness, infertility, decreased breast tissue, increased muscle mass, android body habitus, and clitoromegaly may occur. Management of hyperandrogenism. Management of hyperandrogenism symptoms include using of anti-androgens such as cyproterone acetate, spironolactone, and flutamide. Cyproterone acetate is a synthetic steroidal anti-androgen, progestin, and antigonadotropin. Spironolactone is aldosterone antagonist, and flutamide is a synthetic non-steroidal anti-androgen. Next syndrome, non-classic congenital adrenal hyperplasia. Non-classic congenital adrenal hyperplasia is characterized by milder enzyme dysfunction and manifests commonly in adolescence or adulthood. Although some patients with non-classic congenital adrenal hyperplasia may be asymptomatic, hirsutism is the most common symptom. The ACTH stimulation test is the best screening test for evaluating adrenal gland functions. Asymptomatic patients with congenital adrenal hyperplasia do not need glucocorticosteroid treatment. If the main concern of patient is infertility, ovulation induction is a treatment of choice. If the patient seeks medical advice because of hirsutism, anti-androgens may be used. Next, androgen-secreting adrenal tumor. Primary adrenocortical carcinoma may be associated with excess androgen secretion, and sometimes cortisol may also occur. Primary adrenal carcinoma is a rare disease with the incidence 1 per 600,000 to more than 1.5 million, and prevalence 4 to 12 per 1 million. Female patients may exhibit virilization with very high levels of disulfide, testosterone, and urinary 17 ketosteroids. Primary adrenocortical carcinomas are highly malignant with a poor prognosis. Tumors are usually larger than 6 centimeters, invade the capsule, metastasize early, and typically recur after surgery. It is the best prognostically bad tumors. Next situation. You hear this word several times today. It is adrenal incidentaloma. Adrenal masses are often discovered incidentally and then termed adrenal incidentalomas. The differential diagnosis of adrenal incidentaloma includes many primary, metastatic, benign, and malignant entities. The treatment of hormonally active adrenal incidentaloma is surgery. The treatment for malignancy depends on cell type, spread, and location of the primary tumor. Non-functional adrenal incidentaloma is not premalignant, and surgical excision is not indicated. Pharmacologic doses of synthetic glucocorticosteroids are used in a wide variety of diseases and their anti-inflammatory and immunosuppressive effects. Two main clinical problems arise with the chronic use of pharmacologic doses of glucocorticosteroids: iatrogenically induced Cushing syndrome and adrenal insufficiency on abrupt cessation of therapy. Alternate day therapy and avoidance of nighttime doses are associated with less suppression of hypothalamic pituitary adrenal axis, like physiological replacement of these hormones. And it makes discontinuation of glucocorticosteroid therapy more easy for the patient. Prognosis and prophylaxis in a patient with adrenal gland disorders. Prognosis depends strictly from the disease nature, the clinical manifestations, quality of treatment, and compliance of all its prescriptions. There are no known lifestyle changes to lower risk of developing essential adrenal gland disorders. The following dietary and lifestyle consideration may support healthy adrenal function: avoiding simple carbohydrate calorie restriction, limiting stimulants, exercising, maintaining a positive outlook and good self-esteem, adequate sleep, and regular intervals. And abbreviations that we used for today, I'm trying to explain all of them. For today, that's all. It's all material that I want to tell you. As usual, I ask all students who listen in the lecture, leave the name and your group number in the comments under the video. If you have questions or comments, I'm waiting you on our Facebook page or in comments under the video too. And if you want to check your knowledges, please answer on the questions that I ask you during the lecture. I see you in 1 week. It will be one more very interesting lecture in endocrinology. And for today, goodbye.